Okay, good morning. So for our first topic in the reporting is all about the megaloblastic anemia. Now, I chose a journal titled Severe Megaloblastic Anemia, Vitamin Deficiency, and Other Causes. This was a journal published by the Cleveland Clinic Journal of Medicine last March 2020. Now, to give a summary of the journal would discuss the different causes of your megaloblastic anemia, such as the two most common cause, which is your vitamin B9, folate deficiency, and vitamin B12, also known as your cobalamin deficiency. Now, the topics to be discussed would be the etiology of the megaloblastic anemia, the pathophysiology, and the lab presentation of patients with megaloblastic anemia. Now, the etiology of megaloblastic anemia would be one of the two most common causes would be the problems related with your vitamin B9 and vitamin B12, specifically malnutrition and malabsorption. So we're going to tackle them one by one. Now let's tackle first. Number one would be your vitamin B9, also known as your folate deficiency. Now generally, folate can be found in green leafy vegetables, fruits, nuts, eggs, and meat. Now, normal body storage of folate would be around 5 to 30 milligrams, and the recommended daily allowance would depend, but is around 400 microgram in adults and 600 microgram during pregnancy. Now, vitamin B9 deficiency would usually be due to the following. When you have reduced intake, now you would have reduced intake seen in different types of diet. So let's take a look at these diets to further elaborate on this. Now, diets that may cause your folate deficiency would include, number one, your keto diet. Now, your keto diet would come from the ketosis, wherein it is a type of diet wherein there is increased consumption of fats or lipids. There would be lack of vegetable, nuts, eggs, and red meat, thus causing your folate deficiency, and that would sooner or later lead to megaloblastic anemia. Another type of diet that may cause folate deficiency is your low carb, low protein diet. Now in this diet, the amount of meat and vegetables is limited, and it could as well affect your folate levels. And another type of diet is for those individual taking high carbohydrate diet in impoverished countries. An example of this is those eating high starch content such as your cassava and potatoes. So that would lead to folate deficiency, leading also to megaloblastic anemia. Then another cause in reduced intake is seen in alcoholism. So let's take again a look to further elaborate on this. Now, the effect of alcoholism to folate deficiency. Now, the first one would be dietary inadequacy. So to those alcoholic, they would suffer from chronic alcoholism. They would tend to choose alcohol more than a healthy, nutritious meal. In my experience during my childhood days, whenever I went to the province, I always saw some of my relatives that they would rather drink alcohol early in the morning instead of having a healthy breakfast. So that could lead also to folate deficiency. This is more of a psychological state problem. And then another one would be intestinal malabsorption. So due to the continuous intake of alcohol on a daily basis, it may affect the enzyme gastric alcohol dehydrogenase. Now your ADH, this is the one responsible for breaking down most of the alcohol being secreted through waste. Now, due to the continuous alcohol intake, there would be defective ADH. This would cause your increased alcohol in the stomach with lesser amounts of ADH to metabolize the alcohol, causing your stomach lining inflammation, ulcers, and even could affect the pH of the stomach acid, leading to the malabsorption of nutrients and vitamins. So basically, due to the constant arrival or consumption of alcohol in your stomach, it already damaged the linings of your stomach, the parietal cells, which are important in absorbing certain substances, specifically your vitamins and nutrients. So that would lead to also to folate deficiency, causing also your megaloblastic anemia. Then another cause for your vitamin B9 is decreased absorption. So this would be caused by different disorders affecting nutrient absorption. So this one would technically be more, the organ affected here would be more on the stomach, the small intestine and the large intestine. So one of this disorder is your celiac disease. So let's take a look at this. So your celiac disease is an autoimmune disorder that is triggered when eating gluten. So gluten could be found in your wheat, barley, rye, and other grains. So this is a type of autoimmune wherein antibodies are produced by celiac disease when triggered and would damage a part of the small intestine. Specifically the villi, which are the tiny hair-like projections in the small intestine, which are also responsible for absorbing nutrients and vitamins. With damaged villi, this would now lead to malabsorption of vitamin B9 and other essential nutrients. So that's your celiac disease. Then another type would be your inflammatory bowel disease. So under inflammatory bowel disease, there are two types of disease that could cause decreased absorption. First one would be your Crohn's disease. Now, in Crohn's disease, this is a type of inflammatory bowel disease characterized by swollen and irritated small intestine. The cause for Crohn's disease is until now idiopathic. So when you say idiopathic, the cause is unknown. So it could be autoimmune, it could be acquired, it could be hereditary. But as of now, based on the readings, there is still no known cause for Crohn's disease. Now, one of the effects of Crohn's disease is chronic diarrhea that would lead to malabsorption of nutrients. Ulcer and inflammation of the linings of the small intestine would also affect the absorption of your vitamin B9. So there would be continuous defecation due to the chronic diarrhea, and this could also lead to inflammation of the linings, leading to malabsorption of your folate. And the last one under your inflammatory bowel disease would be your tropical sprue. Now in tropical sprue, this is characterized by the inflammation of your intestines caused by certain bacteria that have replaced the normal flora of the stomach. Now, a fact about your tropical sprue is that this would usually be seen in Caribbean countries, thus derive the word tropical. Now, there would be overgrowth of invasive bacteria that would irritate the stomach lining, preventing the absorption of nutrients and vitamins such as your B9 and B12. So basically, instead of having your normal flora in the stomach, certain invasive bacteria replaces them. This would cause irritation to the stomach lining and would again affect the absorption of your necessary vitamins. Then treatment for tropical sprue may include your sulfamethoxazole, trimethoprim, oxytetracycline, and your ampicillin. Ay po pala. Wait lang po. Okay. Then another cause for your vitamin B9 deficiency would be increased demand. So there are around 4 reasons why there will be increased demand. The first one would be in pregnancy. Now, in pregnancy, in consideration, you have to consider that in pregnancy, vitamin B9 is a very important vitamin because this is necessary for genetic material synthesis during gestation. So as you know, you have in pregnancy, you're carrying a fetus. The fetus would require increased vitamin B9, which would allow it to develop the genetic material, the DNA, and as well as for the mitosis. Now, in gestation, vitamin B9 helps in the mitosis stage of the cells of the fetus. And due to this increased demand of B9 of the fetus, there is the possibility for the mother to suffer from decreased vitamin B9 in her circulation, provided that no remedial supplements are given to the mother. So this is more of a case-to-case basis. In cases of the mother is in terms of financial aspect or economical aspect, if the mother isn't able to properly have a good diet the mother has no proper supplement. That's why those who underwent usually undergoing pregnancy would have recommended supplement vitamins for them to be for it to be taken. Then another cause for increased demand is your hemolytic anemia. Now, in hemolytic anemia and vitamin B9 deficiency, hemolytic anemia is a type of anemia characterized by increased destruction of RBC. In hemolytic anemia, there is a need for the body to increase the RBC production to compensate for the destroyed RBC. Now, due to this increased RBC production, vitamin B9, which is necessary for nuclear maturation of RBCs, will be in demand and may affect the normal levels of the body. So the more RBCs that are being destroyed, your body will, of course, compensate for this. And when it compensates, it would use certain vitamins and minerals, such as an example of this would be your vitamin B9. Vitamin B9 is necessary for the nuclear maturation of RBCs. So they would also be consumed in a large amount, leading to increased demand. Then another one would be in your puberty. Now, puberty, folate has been linked to growth and development in puberty due to its function in endogenous synthesis and metabolism of nucleic acid and amino acid. It has also been studied that higher intake of folate in adolescents have been linked to better academic achievement. Ages 14 to 18 would require at least 400 microgram daily dose of vitamin B9 as per recommended dietary allowance. So to simplify this, when a child would usually undergo puberty, they would have increased demand for vitamins and minerals. And if those requirements aren't met, such as your vitamin B9 deficiency, it could lead to your megaloblastic anemia. And the last one would be seen in eczematous conditions. Now, an example of this eczematous conditions is your atopic dermatitis. Now, this is a skin disorder caused by increased IgE as a form of allergic reaction. Now, in one study from your John Hopkins Children's Hospital, it was found that low levels of serum folate would cause increased levels of IgE that may trigger asthma, wheezing, and in some cases, atopic dermatitis. So the exact mechanism on how low levels of folate increase IgE is still unknown and would require further studies. So that's your vitamin B9 folate deficiency causes. Now let's look at the vitamin B12 common causes. So we have your autoimmune gastritis, celiac disease, inflammatory bowel disease, and surgical gastrectomy. So basically in these four diseases, you would have problems with stomach absorption of the vitamin B12. So I wouldn't elaborate on that anymore since I hope you understood somehow the it has the same mechanism as in your B9. Then less common causes would be seen in nutritional deficiency, usually seen in those undergoing a diet of vegans. Then we have your nitrous oxide abuse. So let's tackle on the nitrous oxide abuse. Now, nitrous oxide is used in cases in the medical field and food industry. Now, this would induce a state of euphoria. In some laboratories, clinics, this is usually used as a anesthesia. So one effect of continuous intake of nitrous oxide that it would inactivate vitamin B12 through oxidation. This inactivation can lead to neurological symptoms due to the absence of methionine, which is necessary for your myelin sheath production. And then we also have your Diphyllobotrium latum infection. So in your Diphyllobotrium latum, remember, if you still recall in your undergrad, this is a type of cestode, and they would have in the head part what you call the scolex. Now, this collex would attach to the linings of the stomach. And would cause competitive absorption. So instead of having only the stomach or your normal body absorbing the nutrients, your Diphyllobothrium latum would also um, competitively absorb the necessary nutrients and vitamins. Then we have your pancreatic insufficiency. So this would refer to your amylase and your other enzymes, wherein there would be a lack of breakdown of food matter. So if the food isn't properly broken down, the vitamins, the minerals aren't usually absorbed properly. They are excreted along with the other food matter. So that's the least common causes of your vitamin B12 deficiency. Now let's look at the drugs causing megaloblastic anemia. So drugs that would affect your purine and pyrimidine synthesis. Now, an example would be under purine synthesis would be your immunosuppressants such as your azathioprine and mycophenolate mofetil. Chemotherapeutics such as purine analogs, fludarabine, cladribine, and thioguanine. Allopurinol, which is a xanthine oxidase inhibitor used to treat gout. While you're affecting the pyrimidine synthesis would include the immunomodulatory drugs such as your lefonamide and teriflunomide, chemotherapeutic drugs such as your cytarabine, gemcitabine, and fluorouracil. Methotrexate, which is an immunosuppressant and chemotherapeutic drug, sulfa drugs, and trimethoprim. So let's look at the pathophysiology of your megaloblastic anemia. Now, whenever there would be vitamin B9 or vitamin B12 deficiency, this would lead to your impaired DNA synthesis and delayed cell division. So let's look at the impaired DNA synthesis. Now, in the primary role of folate would be to donate metal groups in DNA synthesis. Now, vitamin B12 is a cofactor in the reaction that would recycle the 5-methyl tetrahydrofolate back to the tetrahydrofolate form. THF would now convert homocysteine to methionine, which is necessary for myelin sheath production and DNA synthesis. Deficiency in your vitamin B12 would cause the 5-methyl tetrahydrofolate to not become THF, causing a deficiency in methionine, leading to impaired DNA synthesis. So to explain this, your vitamin B9 or your folate would usually give methyl groups. Now, these methyl groups with your vitamin B12 would act as a cofactor. Your vitamin B12 would act as a cofactor wherein your 5-methyl THF would become THF again. And this THF is very important, is that it would convert homocysteine into your methionine. And this methionine would allow for your myelin sheath production as well as DNA synthesis. So if there is absence of either your B12 or your V9, the entire process would be affected, and that would lead to your megaloblastic anemia, because I will explain later on how there would be macrocytic cells. So that's one effect wherein there would be impaired DNA synthesis. Then the other effect, if there is deficiency, would be there would be delayed cell division. Now, due to the effect of decreased vitamin B12 and folate, it would cause the nuclear maturation of your hematopoietic cells to undergo arrest. So DNA synthesis abnormality, but will not affect the cytoplasmic growth of the cell due to having normal RNA function. This delayed DNA synthesis would cause a large cytoplasmic cell with no nuclear maturation, thus the word megaloblastic anemia. So there would be, let's say that you have your vitamin B12 and B9 deficiency. So instead of having the nuclear and your cytoplasmic ratio to undergo normal maturation, what happens is that your nuclear would undergo cessation. It won't mature, but the cytoplasmic would continue to mature, leading to a very large cell with a very small nuclear material, or in some cases, the absence of nuclear material. That's one of the effects, delayed cell division. Then there would also be defective nuclear maturation leading to your megaloblastic anemia. So that's the pathophysiology. Here are the lab presentation of your megaloblastic anemia. There would be the presence of macrocytic cells due to increased cytoplasmic maturation, decreased hemoglobin due to the abnormal structure of your RBC. So in a very large, in a macrocytic cell, hemoglobin content won't be able to be properly be in the normal context. Then elevated MCV due to the increased surface ratio. There will be the presence of macro-ovalocytosis, anisocytosis, which would refer to your variation in size of the cell. And poikilocytosis would refer to the variation in shape. Then your RDW is high. Presence of Howell-Jolly bodies, which are your DNA remains or remnants. Reticulocytopenia, which you have your decreased retic count. Hypersegmentation of granulocytes. Neutropenia could also develop in later stages. Serum B12 levels less than 200 picograms per ml, and folate levels less than 2 nanograms per ml. Then clinical presentation as well would be vitamin B12 deficiency can cause subacute combined degeneration of the dorsal lateral columns of the spinal cord. Patients may experience bilateral and symmetrical paresthesia and decreased vibratory and positional senses. Psychiatric manifestation would include memory loss, delirium, dementia, depression, mania, and hallucination. So the most common hematologic manifestation of megaloblastic anemia would include macrocytic RBC in the peripheral blood, megaloblastic precursor cells in the bone marrow that would exhibit nuclear to cytoplasmic desynchrony, ineffective erythropoiesis that would lead to intermedullary hemolysis, classically with high lactate LDH and undetectable haptoglobin, but without schistocytes in the peripheral. So here we have your difference between pernicious anemia versus megaloblastic anemia. So just to give you an idea, pernicious anemia would usually be a type of megaloblastic anemia. Pernicious anemia is usually caused by the lack of your intrinsic factor. So what is this intrinsic factor? Now, your intrinsic factor would usually be produced by your parietal cells of the stomach. Now, once produced, this intrinsic factor would have what you call a receptor on its molecules. Now, this receptor would target your vitamin B12 and they would form a complex. So your vitamin B12 would attach to the intrinsic factor. After attachment, it would be absorbed by the intestine, the terminal part of the ileum. Then it would go to the portal circulation. So when you say portal circulation, we're talking about the liver veins. It would enter this and it would be stored in the liver at around 1,000 micrograms, and it would be released into the circulation when needed. Now, what happens in cases wherein there would be megaloblastic anemia? Now, there would be anti-intrinsic factor antibodies. Now, something about pernicious anemia is that it would usually be seen in autoimmune diseases. So there would be what we call the production of the anti-intrinsic factor antibodies. So there are two ways on how this antibody would cause your pernicious anemia. One would be by blocking, it would block the binding site of the vitamin B12 to intrinsic factor. So there would be no complex. If there's no complex, it won't be absorbed by the intestine. Then another one would it would bind with the site on the intrinsic factor. So again, it would in your chemistry, if you recall about the enzyme, it would somehow replace. What happens is that instead of the intrinsic factor vitamin B12 complex, what happens is that there would be the presence of the anti, let's just call it the let's just use the word antibody. There will be the antibody and vitamin B12 complex. So basically, the intrinsic factor wasn't able to attach to the. So that would happen to your pernicious anemia. And a test for this is your intrinsic factor antibody test, which you could use it for diagnosis. Then other findings for your etiology. So I've already discussed this, alcoholism and such, clinical manifestations and all. Treatment for pernicious would be parenteral vitamin B12 1 to 2 times per week until symptoms improve. Then for folate deficiency would be oral folate on a daily basis. Monitoring and follow-up would should be done for improvement of neurological symptoms for vitamin B12 deficiency. Monitor hematologic response, complete blood count, and for your folate, monitor hematologic response such as your CBC. So here are the reference. So that ends my presentation. Thank you. Sorry if matagal.
Okay, so can you hear me?
Yes, ma'am.
So, Sir Peter, in a nutshell, what are the, if you're going to summarize the major causes of megaloblastic anemia? So the mechanisms rather leading to megaloblastic anemia. Can you highlight these primary causes?
So the primary causes, ma'am, would be basically malnutrition and
Okay.
malabsorption. These two.
Okay, so in general, you have malabsorption and malnutrition causes. Okay, so another one would be, so you mentioned some other causes apart from nutritional
Uh,
causes.
in some cases, ma'am, there would be autoimmune disorders such as your Crohn's, your tropical sprue, and your celiac diseases.
So it could be a form of autoimmunity disorder. So another would be,
Natural growth, such as puberty and pregnancy, ma'am.
okay, so if there is in physiological, we could call that physiological causes. So in pregnancy and in growth spurts.
Yes,
So
ma'am.
in puberty and adolescent stages. So another would be,
Um, it could be due to infection, ma'am, such as your parasitic infections in Dipholybotrium latum, as well as replacement of the normal flora of the stomach seen in tropical sprue, ma'am.
Okay, so you have parasitic infection, particularly with tapeworm. Okay, and then you mentioned also about what's the other one, the last one, sir, that you just mentioned?
The
Changes
replacement
in
changes
is
in
it
the norm.
dietary changes.
Yes, ma'am. Yes, dietary changes also. Mhm.
Okay,
If
so the one that you described about the Caribbean
yeah, uh,
diet.
yeah, yeah, yes, ma'am. The tropical sprue. This one
Okay,
that would cause the replacement of the normal flora.
okay. Are we? Is there any drug induced cause also?
Drug-induced cause would be this one, ma'am, seen in the purine synthesis and pyrimidine synthesis because it affects the cell division as well as DNA synthesis. So your purine and pyrimidine, these are the drugs, ma'am, that would cause megaloblastic anemia.
So and then you also have an idiopathic cause
Yes,
seen
ma'am.
in.
The idiopathic cause was seen in your Crohn's disease, ma'am. So this is an inflammatory bowel disease.
Generally speaking, when we talk about megaloblastic anemia, so it is a general disorder. Okay, so it consists of a wide spectrum, okay, of causes or etiology. Okay, so meaning to say non-specific. When you see a megaloblastic clinical impression or blood picture of a patient, it doesn't truly point out to a specific disorder right away, right, Sir Peter?
Yes, ma'am.
So you have to conduct some ruling out uh, diagnosis in order to establish what is the true uh, what leads to the megaloblastic anemia of this particular patient. Okay. Now, sir, you mentioned about celiac disease, right? So
Yep.
that celiac disease is an example of an autoimmune disorder
In gluten.
characterized by the production of antibodies, right?
Yes,
So
ma'am.
the antibodies will destroy the small intestine. Can you specify the antibodies? Antibodies
Uh,
against what?
this was against gluten, ma'am. What? Antibodies. The antibody. I forgot the name, ma'am. Wait.
It's okay. So we are interested also in knowing the why in celiac disease, for example, antibodies are produced, and then these antibodies would destroy portion of the small intestine. Okay, so that there is impairment of the absorption of nutrients and vitamins. So definitely, this antibody has a name. Okay, so we are interested in knowing
The
what particular. Okay.
the general type of antibody, ma'am, would be the IgA informed. The reason why it's IgA informed because IgA would usually be found in the mucosa, in the mucous membranes. Based on this article I'm reading, it's known as your tissue transglutaminase IgA. So this is the antibody that would trigger the celiac disease, ma'am, that would attack the small intestine, specifically the villi.
Okay, so can you please tell us what how important is tissue transglutaminase? Because if it's the one that is being attacked by the IgA, so what is the role of this tissue transglutaminase? That in the sense that if it becomes damaged, okay, so the absorption of the nutrients will become affected. Okay? So you look up, Sir Peter,
Okay,
the
ma'am.
role of the tissue transglutaminase in nutrient absorption. Okay, but we all know. Okay, so according to the presentation, okay, so the class of the antibody produced in celiac disease is IgA. Okay, so because IgA forms part of the mucosal immunity. Okay, So the follow-up information we need to know is the role of the one that becomes damaged. So this is your tissue transglutaminase, so enzyme.
Noted, ma'am.
Sir Peter, you mentioned also about tropical sprue, right? So which is common in the Caribbean countries.
Yes, ma'am.
Okay, so what is it in the Caribbean countries that makes this the people develop sprue?
It's their diet, ma'am. If it's high in, I'll look it up, ma'am, and present it. But it's all about their diet, ma'am. I'm not sure on the exact
Okay.
details.
All right. So probably there is a chemical present or a molecule present in the diet, in the food that might have these people develop tropical flu because based on the information, they are singled out, right? So they are singled out that it's particular in the Caribbean country. So it's just that what makes it so special in their diet, that is there a certain substance present that leads to tropical flu. So that is also interesting to know, Sir Peter. Okay,
Noted, ma'am.
so you can probably share it with us in the next maybe next week, right?
Yes, ma'am.
One of the laboratory manifestations, or rather diagnosis, in megaloblastic anemia mentioned earlier was hemolysis.
Yes,
Is
ma'am.
it? Can you?
Yeah.
Okay.
Hemolytic anemia, ma'am.
Okay. So which is one of the,
Causes
not
for
all. Okay, not all, but in some cases, hemolytic anemia, right, becomes
it,
apparent.
yes, ma'am. In very severe, siguro, ma'am, severe bleeding, or in severe cases that there would be increased intravascular destruction of your RBCs.
Now, if there is hemolytic anemia, presented, what would be the blood picture? If, say, for example, we look at the peripheral blood smear of a patient who has hemolytic anemia as a result of vitamin B9 deficiency, what will be the
Uh,
appearance?
if I recall, ma'am, since in hemolytic anemia there is increased RBC production, so there would be expected that you would be able to see increased reticulocyte. There's a possibility to see hypochromic hypochromic cells. There's also a possibility to see microcytic, and in some cases as well macrocytic cells. Then there's a possibility that the MCV would be decreased, as well as the MCH. The MCV here will be decreased due to, it's directly related to the size of the cell. So if it's microcytic, there would be decreased MCV, and your MCH would be related to the hemoglobin content. So if it's low, there would be decreased hemoglobin, hypochromic, ma'am.
What is now the predominant morphology of the cell in hemolytic anemia?
The morphological, I guess there would be increased reticulocyte, ma'am, as well as microcytic cells. They would be the one more predominant in hemolytic anemia due to the immediate, due to the, what they call this, rush compensation of the body. So the cells aren't able to fully mature.
So it depends actually if it's an extrinsic or intrinsic type of anemia, but yes, in the peripheral smear of a patient who has hemolytic anemia, so you will also observe for the presence of fragmented RBCs,
Yes, ma'am.
right? So you have,
Schistocytes could be
okay,
seen as well, ma'am.
okay. It's if the condition of, for example, vitamin B9 deficiency is not corrected, okay, so it will lead to a more severe form of your anemia, so which is hemolytic anemia. So there is a tendency to compensate for the ineffective erythropoiesis, for example. So this will trigger more production of RBCs. But then, even if you have more RBCs, the quality of these red cells are not sufficient to compensate for the loss of the RBC. So the natural mechanism, if the RBC, for example, or even any cell is not uh, optimal, okay, in terms of the function, in terms of the appearance. So this cell has to be destroyed. So right, anything that is dysfunctional or useless has to be destroyed. So this is what happens in hemolytic anemia. Okay. Now, so there was also mentioned about in vitamin B12 deficiency. Can you go to the slide about
This one, ma'am.
there is about methionine, the role of the amino acid methionine.
This one, ma'am.
So based on this explanation, it appears that the deficiency itself in vitamin B12 is only secondary. I mean the impairment of the DNA synthesis is secondary to the decreased methionine levels, right?
Yes, ma'am.
The role.
The
Okay. Yes. Proceed.
the methionine kasi, ma'am, this is the if I recall in the biochem, this is the start codon. So if there is no start codon, there would be no DNA replication. So it's very necessary, ma'am, in the uh, production of your DNA as well as the myelin synthesis. That's why in some cases the cell would have very as the RBC would have no nuclear maturation because there is no DNA replication. Yun.
Um, so vitamin B12 deficiency will cause a deficiency in the methionine. Okay.
Yes, ma'am.
So again, the role of methionine in DNA synthesis is
The start codon, ma'am, or the start of the amino acid that would initiate DNA replication.
okay. Now the name itself, megaloblastic anemia. Okay, so in a layman's understanding, when we speak of megaloblastic anemia, it implies that the cells are big, right? The term megalo
Yes,
means
ma'am.
big, and then blastic is immature. Okay,
Yes, ma'am.
why is it that there is nuclear hypersegmentation in a megaloblastic anemic patient?
Um, this one, ma'am, the hypersegmentation of granulocytes.
Is it only apparent for granulocytes? Meaning
Uh,
nuclear hypersegmentation will only be observed in granulocytes?
I think, ma'am, it's only present in the granulocytes because in the RBC, since the cell would have a higher cytoplasmic area. Due to the increased cytoplasmic area, ma'am, uh, there's a possibility that the nuclear material would only be around in the center part in a very small part. So basically, the entire part here would be covered with your RNA content. Then the small part
So,
here would be the DNA.
all right. So the nuclear hypersegmentation will only be observed in granulocytes but not in RBCs.
Yes, ma'am. I think so.
Anyone from the class may also comment on this. Okay, so if you have something to share, please do so. Okay, now in terms of the red blood cell, now can we say that in megaloblastic anemia, apart from the nuclear hypersegmentation of the neutrophils, particular the neutrophils, when we check the RBC, okay, is it possible to see nucleated RBC?
I you're talking about the reticulocytes, ma'am. Am I correct?
No, nucleated RBC is different from reticulocyte.
The okay, the stages below the reticulocyte, ma'am. Am I correct?
In the erythropoiesis series, which comes first, the nucleated RBC or the reticulocyte?
It's the nucleated RBC, ma'am. Then
Okay,
the
so
reticle.
yeah,
If, since that would depend, ma'am, on the cause, but most of the time, let's say in which anemia was that? Let's say that in hemolytic anemia, ma'am, since there is increased production, there's a possibility that the younger cells are also released already into the circulation. If you recall that the usually the cells would mature in the bone marrow, but in some cases, depending on the compensant on the cause, that the body can release younger cells already into the circulation, ma'am. So it's possible po.
okay. So but let me ask. So in megaloblastic anemia, okay, so we all agree that the patient's blood picture would have nuclear hypersegmentation. Okay, right? So everyone agrees that's number 8. Okay, hypersegmentation of granulocytes. Okay. Sir Peter, if the granulocyte is hypersegmented, are we saying that it is immature?
Yes, ma'am. It's a possibility since in the hematopoietic series, if I recall in what I taught in Hema 1, in the hematopoietic series, the rule is that as the cell matures, as a cell matures in the hematopoietic series, there would be decreased nuclear material. So if there is a possibility of hypersegmented, so when you say hypersegmented, they would have increased lobes, increased nuclear lobes. So there's a possibility. There is the fact that it is a immature cell, ma'am.
In the granulocytic series, okay, so we go to the granulocytic series. Okay, so what is expected? What is the expected nuclear maturation in the granulocytic series?
It should
What
have
do we expect in a normal?
it
Okay.
should have 2 to 5 lobes, ma'am. In hypersegmentation, it would have greater than 5 lobes.
Now, hypersegmented granulocytes in megaloblastic anemia is seen in the peripheral blood smear. Can these hypersegmented granulocytes be seen also in the bone marrow or not
Uh,
anymore?
yes, ma'am. They can be seen in the bone marrow since some hypersegmented are still maturing in the bone marrow. That's why, ma'am, in a normal person, normally, youngs they would still mature in the bone marrow, but the young cells, the young cells are usually only seen in the peripheral blood in cases of disorders or in need of compensation. The bone marrow is forced to release them as soon as possible to compensate.
How about in the bone marrow? What do we see in megaloblastic anemia?
In the bone marrow, ma'am, in megaloblastic anemia, you could see the different blasts, such as the promyeloblasts. I'm not sure, ma'am, on the exact content. Sorry, but most likely, ma'am, in
Share it
megaloblastic
with us
anemia.
next.
Yes,
Share
ma'am.
it with us next week, Sir Peter.
Okay.
Na the bone marrow morphology in a patient with megaloblastic crisis.
Yes, ma'am.
Okay, just so we can readily compare it with peripheral blood picture. Can you share it with us next week?
Yes, ma'am.
Um, can you clarify the blood morphology in a patient with intrinsic factor deficiency seen in pernicious anemia?
It's actually the same, ma'am, as in your folate and in your megaloblastic anemia, because, ma'am, under megaloblastic, this pernicious wait, sorry, pernicious anemia, ma'am, is a type of megaloblastic. So most of the time, ma'am, they have the same clinical presentations. They would
So you
have
just need
the, they have the
run some
difference.
tests. Okay.
They would have the difference, ma'am, when it comes to the neuropsychiatric. And also to differentiate them, you have to check the vitamin levels. So if it's decreased vitamin B12, it's most likely your pernicious. But if it's decreased vitamin B9 or your folate, then we'll go with the general type, which is the megaloblastic anemia.
Um, okay. So in megaloblastic anemia, okay, so it was highlighted that it is a kind of ineffective erythropoiesis, right, Sir Peter?
Yes, ma'am.
Okay. So can we now ask if the bone marrow is it hypocellular, hypercellular, or normocellular?
Um, that would depend again, ma'am, on the cause of the megaloblastic anemia, because the main two causes, if you still recall, are malabsorption and malnutrition. So technically, ma'am, this wouldn't have any direct impact on the bone marrow. So I guess it would be normocellular, ma'am. But depending on the cause, as I mentioned, if it's hemolytic anemia, most likely there would be a hypocellular appearance on the bone marrow due to the constant releasing of the young cells.
Okay. So probably you can insert a tabulation and then you share with us next week.
Okay, ma'am.
Okay.
Tabulation, ma'am, on the
Cellularity of the bone
cellularity.
marrow
Cellularity.
based on the cause that you just mentioned.
Okay, ma'am.
So and then vitamin B12. Okay, so we saw it earlier that in vitamin B12 in pernicious anemia, it's possible to have neurological symptoms, right?
Yes, ma'am.
So clinical presentation. Okay, so right. So
Yes, ma'am.
There is can you connect that with the other slide? So you showed it
Uh,
about the B12 and the myelin sheath.
this one, ma'am.
There's a slide. Okay. So that
So,
explains why there is a neurologic symptom in B12 deficiency. It's because of the effect of the reduced methionine, okay, which is also essential in myelin sheath production. Am I correct, Sir Peter?
yes, ma'am. The myelin sheath, ma'am, is the covering of the nerves. So if there's a defective, and if you recall, most of the nervous system would be covered with the nerves. So if there's defective myelin sheath, you would have also defective nerves leading to the different neurological symptoms. In some cases,
So you see,
there would be
so you see
memory
how
loss.
important vitamin B12 is. So are you taking your multivitamin supplements, everyone? So because if there is deficiency in B12, you look at the clinical presentation. So you see, patients will have psychiatric manifestations such as memory loss, you have delirium, depression. So you see, if probably you encounter a person who exhibits these manifestations, would can probably be explained, okay? Or maybe one of the causes could be a vitamin B12 deficiency. So how that's how important B12 is. Okay, so okay. So how about the audience? Do you have any other questions to Sir Peter before we have a short session break?
Yes, Sir Alex.
Hello, Sir Peter.
Yes.
Is that a very I'm just curious because of uh as Ma'am Joy said, the hypersegmentation of the neutrophils. And also in the laboratory picture we can see neutropenia developing in the later stages. I'm just curious why specifically the neutrophils are affected uh during megaloblastic anemia. Yun lang po.
Okay, that's a very good question, Sir Alex.
Thank you.
I'll get back to you next meeting.
Sorry, sir.
I'll take
Okay.
take note of
So
that, Ma'am
yeah,
Joy.
so this is a very good discussion, right? So it's a very good discussion in the sense that we our our eyes are becoming more open, okay, in understanding the pathophysiology of a patient, because in your during your college undergraduate years, yeah, we know what is megaloblastic anemia, what do we expect, okay, but we have to go deeper into the details, okay, so how the maturation series, okay, in the cellular development, okay, become arrested. So there is an arrest, okay, in the developmental series, and you see the scope of the effect of nutrient deficiency. It's not just the RBC that becomes affected, but also the other cells. Okay, so there is an effect in the nuclear cytoplasmic ratio. So versus what we expect in a normal development, for example, in the granulocytes. Okay, so we expect that there will be fusion. Okay, there will be fusion, which is a sign of maturation. So if there is hypersegmentation, so you mentioned up to 5 lobes only, Sir Peter, right?
Yes, ma'am.
So that's the clue that we have that this granulocyte really underwent maturation. So, but beyond that, so if there's no further fusion of the excess lobes, and that's a sign that probably there is a cause, okay, that led to this failure to fuse. Okay. Last question na lang, Sir Peter.
Yes, ma'am.
Okay. So if we check the peripheral smear and then we see hypersegmented neutrophil, on the average, how many cells do we need in order to establish that there is a megaloblastic anemia? Is there a specific range of
Uh,
hypersegmentation or count?
Technically, ma'am, in megaloblastic anemia, this is not a major criteria in establishing that it is megaloblastic anemia. The main criteria for this, ma'am, if you want to consider it as megaloblastic anemia, you have to see the presence of the macrocytes and other large cells. But this is more of a parang supporting, but I have no idea, ma'am, on the number of cells or the number of hypersegmented cells to establish it as a megaloblastic anemia, because, ma'am, this isn't really considered as a major establishing factor to be considered megaloblastic. Because in some cases, ma'am,
Yeah.
in if I recall, in the WBC disorders, there's a disorder, I forgot the name, if it's Alder-Riley or I forgot the exact name, but it's a disorder wherein the granulocytes have hypersegmentation.
Okay. So you have to verify it, Sir Peter.
Yes, ma'am. I'll
Can you
include it.
verify it? Because based on literature, the hypersegmented neutrophils together with the macrocytes are highly specific for megaloblastic anemia. But we
Okay.
have to verify it. Can you verify the information?
Yes, ma'am. I'll include it
Okay,
in
and then we come up with a unified conclusion.
okay,
Okay.
ma'am.
All right. So I have no further questions with regards to the presentation of Sir Peter. Okay, comments are welcome from the rest of the audience. Okay. Do you have any other comment? Now, in the clarification that you will present next week, Sir Peter, kindly include a picture or a diagram of the developmental series affected by uh, vitamin deficiency in megaloblastic anemia. Can you please show the specific stage where the problem sets in the erythropoiesis or hematopoiesis series. Can
All
you
right.
do that?
Yes, ma'am.
Okay.
I'll include.
Okay. So short session break. So we resume at time check is 9:19. Okay. So next presenter, please be ready at 9:30 a.m. Okay. Okay. We resume 9:30 for the next presenter. Okay. Okay. You can have your short break. See you in a while.